Good afternoon, everyone. Welcome to the medical retina session. We have Chairperson Dr. Swarna Bisetia Gupta, Dr. Rajpal Vora, Co-Chair Dr. Tathagat De, Dr. Abhijit Chattopadhyay, Dr. Anupama. Okay. So I am Dr. Sonia. I'll be the moderator for the session. So we are starting the session with Dr. Anushri Naidu's talk on OCT angiography analysis beyond its retinal biomarkers. Dr. Anushri.
Good afternoon, everyone. I would be discussing in brief about OCT angiography, its artifacts, retinal biomarkers that are already described in OCT angiography, the novel methods of analysis and biomarker-free diagnostics. It is a non-invasive, high-resolution, depth-resolved imaging modality analogous to ultrasound. It provides high-contrast imaging of retinal and choroidal vasculature that are amenable to quantification. It offers the capability to identify and characterize biomarkers important for clinical practice and therapeutic research. There are mainly time domain and Fourier domain systems that help. The Fourier domain systems are more helpful as the speed of acquisition of image is very high. The SSOCT and SGOCT are the two types of FDOCT which are useful in performing OCT angiography. In SGOCT, basically a broadband light source transmits the light to the beam splitter, which then splits the light to the reference part and the sample, that is our patient, and which is then transmitted to the spectrometer, which creates a interference pattern, and it is then Fourier transformed. In SSOCT, a frequency swept light source is used, and the similar methodology is used, except for the fact that in the end there is a detector which detects and transmits the image and creates a Fourier transform. The various wavelengths used in OCT angiography are 840 nanometer and 1050 nanometer. The high wavelength gives better beam penetration and axial resolution, and it is not visible to the patient, hence motion artifacts are less with high. The various algorithms used for OCT angiography are full spectrum and split spectrum. There is a Doppler shift algorithm. It uses blood flow induced phase difference between adjacent A scan to calculate the Doppler frequency shift as the contrast between the blood vessel and static tissue. It is not well suited for choroidal and retinal microvasculature as the blood vessels are perpendicular to the OCT beam. Then the next is speckle variance. In speckle variance, the OCT signal acquired as a result of partially coherently backscattered light from biological tissue. Due to the presence of moving particles in the biological tissue such as red blood cells, the speckle pattern varies with time and can be quantified by speckle variance calculations using either interframe or interline comparisons. This is an example of image obtained by speckle variance. The split spectrum amplitude decorrelation angiography basically decorrelates the image into the 11 pairs of low resolution OCT amplitudes. The 11 decorrelation frames and then create an average decorrelation. Other algorithms used are phase variance and OMAG and SSAPAG used to create the phase variance. The various artifacts in OCT angiography are pupil viginating artifacts, defocus, motion artifacts, shadow artifacts, projection artifacts, and artifacts from segmentation. Pupil viginating artifacts means the artifacts created from the edge of the pupil as a result of low reflectance. The defocus to small vessels will appear blurred, reduced flow signals, dim structural OCT image, low strength signal strength, astigmatism, higher order aberration, and dry eye can cause same problem. Motion artifact it is caused by the eye movement. Fast motion can leave residual artifactual flow. Signal specifically on the bright structures like RPE appears as 2 to 3 bright lines on NFAS OCT. Large microsaccades appear as disjointed blood vessels, and blinking dark line appears on NFAS as OCTA. The shadow artifact flow signal is dependent on the reflectance signal from which it is derived. If OCT beam is blocked by the retinal structures or opacity in the media, there will be dark regions on both OCT and OCTA. Causes of focal shadowing are large blood vessels, vitreous opacities, hemorrhage, drusen's, hard exudates, and RPE detachment. RPE defect causes focal brightening of the reflectance and flow signal. Correlating with NFAS and structural OCT helps identifying shadowing. Shadow artifact is seen in this image. The purple area show areas of normal perfusion, green shows areas of hypoperfusion by the disease, and blue as the area of hypoperfusion caused by shadowing. The NFAS image shows the shadowing as a result of vitreous opacity. The red arrows are suggestive of intraretinal fluid as a cause of shadow artifact. The projection artifact, moving blood cast, flicker, shadow that are interpreted as flow on OCTA and appear bright. These artifacts can be visualized on both cross-sectional and en-face OCT angiograms. On en-face, there is a replication of superficial vasculature on deep vasculature. Examination of en-face OCTA slab of superficial and deep layers together help in identifying these artifacts. This is a demonstration of projection artifact. As we can see, the superficial plexus will project an artifact to the deep plexus, and image sees a better delineation of the neovascularization after removal of segmentation artifact. The artifacts from segmentation pathologies that distort retinal layers can cause errors in automated computer segmentation. These artifacts can be identified using assessment of cross-sectional scan with segmentation overlaid on structural OCT. Manual collection of these poor segmentation can resolve these errors. The retinal biomarkers that are identified on OCT image are perfusion, foveal avascular zone metrics, neovascularization, and vasculopathies. The perfusion includes vessel density qualitative analysis, non-perfusion areas, and choriocapillaries flow deficits. As we can see the vessel density maps in the eye, the top row projection resolved angiogram of the superficial vascular complex, intermediate and deep vascular complex, and in second row corresponding vessel density heat maps are prepared. These vessel density heat maps reveal low vessel density in the area of capillary dropout. The non-perfusion areas are detected using deep learning. This is an image of CRO. I will skip this. Choriocapillaries flow deficits are identified on OCTA. Foveal vascular zone metrics assessing perfusion loss near foveal vascular zone using baseline FAZ region determined from retinal thickness, 3D parafoveal avascular vessels density in the eyes of the healthy control, diabetics without retinopathy, mild to moderate NPDR and PDR images. The neovascularization include macular neovascularization and retinal neovascularization. This is an image showing macular neovascularization. Other vasculopathies are collaterals and microaneurysms. The need for novel methods is lack of standardization of data collection and transparent analysis method, the absence of standardized image grading, interpretation methods, and metric. The novel methods are quantitative microvascular parameters, functional OCTA analysis, deep learning for vessel segmentation, multimodal imaging. The quantitative microvascular parameters include perfusion density and vessel density calculation. Calculating parameters like vessel tortuosity, fractal diameter, and capillary network. I would skip this quickly. Deep learning for vessel segmentation using convoluted neural networks to automatically segment vessels in OCTA potentially improves accuracy and reducing the manual analysis time. Advanced segmentation techniques like UNet architectures help identify complex vascular structures in challenging conditions. OCT seg and MATLABs are used for these purposes. And there's an open toolbox, Octava, which helps us analyze the OCTA images in detail. The functional OCTA analysis and multimodal integrating image integration helps combining OCTA with structural OCT to analyze the relationship. The biomarker-free diagnostics is used by advanced algorithms, and AIOCMTC is the first example of automated imaging. Thank you.
Anybody would like to ask any questions? Dr. Ajay? Very good presentation, and I think she has. Thank you so much.
Next, we'll have Dr. Rajpal sir. Sir will be presenting on optic display. And since we are running 15 minutes late in our session, I would like to request all the speakers to please stick on time.
I will be. Thank you, AIS, for giving me the opportunity to present this case talk on the optic disc maculopathy. So optic disc maculopathy diagnosis has improved these days because of the advancement in the OCT. Earlier we were not able to diagnose, and still we were unable to diagnose. Many of the patients come very late, and so the visibility is bad. With the advancement, we are able to follow up these cases and to predict early the neurosensory detachment or the decrease in vision, so that early surgery can be done. So innovation. So there are two theories as far as the optic disc maculopathy is concerned: Vitreous theory and the pressure gradient. that the fluid is coming from the CSF or not. The exact pathogenesis is not known. In some patient may be vitreous, it may be the CSF pressure or both acting. So with the swept source OCT, there is a deeper penetration. So we can have a depth up to 2.6 millimeter, and we can know the course of and the depth of the pit. So that the management which is coming these days is optic pit, stuffing, we can calculate. Dangers can identify the communicating tract. As you know, the fluid comes not from the optic disc, from the communicating tract which is laterally present. So this was a identify OCT, SWEPSO OCT helps in identification optic disc pit and its communication. Early identify intraretinal fluid and SRF. Identify vitreomacular attraction, specifically over the disc, which is the main cause which has been found, and the prognosticate depending on the ISO junction, RP station, and monitoring of the treatment. So this is the one study where they have done the various swept source OCT. Here you can see the OCT on OCT they defined the optic disc pit, shallow pit or deep pit, and depending on that we can have a treatment later on. And the hole in the lamina cribrosa. You can go through this article. And as far as management of optic disc is concerned, there is non-surgical, surgical. But one of the important although this is rare, the identification of optic disc pit and the follow-up for the development of the maculopathy and neurosensory detachment is very important. So initially laser were tried when there was a vitreoretina was not advanced, then buckling was tried and pneumoretinopexy, and at present plasma vitrectomy with its various modification is the treatment of choice. So there are two things, observation and some people use the carbon anhydrase inhibitors. In optic disc pit, 25 to 75 per eye with optic develop the maculopathy. Resolution is very rare except in the pediatric cases. So now standard of care is that the plasma vitrectomy with or with laser or gas. Earlier we used to do ILM peeling, but tangential traction is not the cause in these cases. This is just to emphasize you. And now these days, because people are thinking the source is from the CSF in some cases, so there is a plugging of the optic disc pit. So these are the things PP will release the vitreous traction. Gas act as a temporary barrier. Let me tell you, one of the European studies, gas has a better prognosis. This I have learned for the last 5 years. Otherwise, there is no need to put the gas, only the X-ray, because this causes a tamponading effect and the absorption of fluids. ILM peeling, as earlier we used to do, but no. Plugging is very important. Some people are trying inner retinal fenestrations and shown the results, but it is very difficult to do, and because of the surgical risk and involvement, we are not doing, but auto allows it. In plugging, one of the sources is the communication. So there are various methods which has been tried: ILM flap, autologous scleral flats, amniotic membrane, autologous fibrin glue, and Hassan et al. Has used the silicon lacrimal plug. So I will show the case one. This is a case when the optic pit was diagnosed 6x6 vision, and you can see the fluid starts from the nasal, fluid was in the intraretinal space, and that it increased. As the vision is still 6x6, it took 3 to 5 years. Again, now you can see the small neurosensory detachment, which can only be picked by the OCT with the high resolution OCT. That is why we are doing 90D, all these things. It is very difficult to pick up and to decide when to do the surgery. Now the vision has become, now the neurosensory detachment has increased. Again vision has become 6/12. Patient is not still symptomatic, but because we know if patient is not being operated, the patient has been convinced, we have done the surgery at this stage, only plasma vitrectomy. So which everybody has seen, PVD induction, and that is all. Now this is the case pre-operative. As you can see at vision 612, 871 thickness and 82 is a neurosensory detachment. And after 1 year of just doing PVD induction, the vision has improved to 6 by 9, and there is a still small defect, and the thickness has decreased 309. This is the only case where we are following for the last 7 years. Now this is the second case. Now the thing is, some cases there is recurrences around 30 to 40%. The percentage not matter. Recurrence is there. So that is why the people have stopping the communication. So this is the one of the case where we have done the, after doing a, as you see, complete vitrection is very important to remove the vitreous traction. And here we are using a scleral plug. So from the sclera we are taking part of scleral tissue. The important thing is we have to have a watertight closure of that pit. The pit communication is deeper, not in the top, so that can be assessed with the OCT, swept source OCT. Now you can see with the VR, I am taking this flap and over the disc, and initially we were afraid because of the damage to the optic disc and circulation and all these things, but now we are confident of putting this scleral plug. Actually we have to identify how much is the size of the optic disc pit before inserting the this thing inside this, because of the we require watertight closure. And we have done ILM peeling, but ILM peeling is not that sufficient. It is not stick to the optic pit. Next presentation. So this is a case, as you can see above. This patient is a IB officer with vision of 636. I think he has come initially. So we have put the plug pointer. As you can see, this is a scleral plug, and you can see here also. So this is the one of the case where there is early resolution of the thing. The difference between just PPV is, in PPV in initial stage 5-6 years back I was not getting that response, and only 60% their fluid absorption are there. But this case, because it was watertight, and within a month fluid has absorbed, he is improved from 6 by 36 to 6 by 9. That to our surprise, because the retina must have been healthy in this case. So this is the old case where you can see the child has this girl has presented with 6 by 36 vision with huge cystic maculocytosis with NSD, and initially we have done PPV gas with laser. 6 months later on there was a recurrences. So again we have done the laser and the SF6 injection, SF6 in this case. Luckily the fovea was attached. You can see the laser mask, and the vision is still 6 by 6 in spite of having a fluid cystic cavity which has decreased, maculocytosis which has decreased, but not completely. Still after 2 years this is the same, but fovea is attached. Patient is lucky. So these are the advantages, disadvantages, and depend on morphology optic disc. Limited studies may dislocate. That's the important thing. Dislocation of the flap is very important in these cases. If we can fix it and decide, that's why the Hassan et al., he has done 20 cases and he has put this scleral plug and shown the 100% results. So another thing is plasma rich growth factor has been tried, and ILMP we have done the study, and we have seen with 6 months to 1 year there's an improvement in CMT and visual outcome. And there's a video which is just for 2 minutes. So this was the initial 3 years back. We have a AIOCMTC. This is to demonstrate the role of AIOCT in these cases. One thing is ILM peeling is not the standard of care these days. We have to do macular sparing, ILM peeling for the plugging of the pit, not to remove the traction, because tangential traction is not the cause in these cases. The tractional is at the vitreous, at the optic disc pit. There is a membrane or adhesion which has been shown by the various OCT, spectral OCT. And in the OCT here also we can see whether there is a thinning of the fovea or not, so that we should be able to avoid. Still people are doing ILM peeling just for the sake of plugging of the pit bed that is easily available. But to me, it is very difficult to plug. So there is other method. People are putting amniotic membrane and scleral tissue. So we have already put this scleral tissue. Thank you for your kind attention.
Very nice presentation, Dr. Vora. I want to know whether you can plug this pit but with autologous platelets also.
People are trying autologous serum. So that is why that thing is with the something with
So
the
is
adding
it
the
not fruitful? Is it not?
people are just doing. There is no study available. They have advised if you can put that thing with the calcium, it plug the hole.
Because
and the
in
basic
place
purpose.
of putting a plug, we
Yes,
can.
yes. In place of plug or scleral flap, this may be the better idea in the futures.
And one thing more, in literature was mentioned the neurotomy on the periphery.
Yes, yes. That is the thing which neurotomy we have tried in CRVO cases are very difficult and complication rate was high. That is why we have not tried here. But Otto et al. Has shown the good results after doing because he said once you do retinal neurotomy, the fluid will comes out and it will close. Let me tell you, it is multifactorial factors. So earlier we used to know only the vitrectomy and we were not able to plug. Now the thing is, if you have to get a result, first do the PPV, remove the traction. If doesn't, then do the thing. The important factor in this case, long-term study is only available with me for the 10 years. In these cases where we do only PPV, the recurrences rate are higher as compared to the if you plug, because you are cutting the both the sources, the vitreous traction as well as the CSF fluid coming from the CSF. Thank you. Anybody? Yes.
And also, what will you do in pediatric patients? Like, because vitrectomy, risk of cataract and all that, how long do you follow up those?
Yes. The case which I have shown is very, belong to one of the doctor, and she was diagnosed in 15. She was diagnosed and 15, the intraretinal fluid starts coming. So there is no visual fall. But what I think is many of the cases which I operated, their vision didn't improve earlier. Because if it is 6/36, it has become 660. But now with this experience, because the two cases which we have operated early, I think that case, first case, we were just one line improvement. And in the second case, again, there was a remarkable improvement. But all other cases which we have done 5 years back, there was not much improvement. That means now we are able to identify early and detect early. We should able to convince the patient. It should be done as early as possible. 618 vision is sufficient, and patients should be able to convince. Because of vitreoretinal technology, microsurgery, everything has improved. So our surgical results has improved. So now don't worry about the thing. Although this thing, 618 vision is sufficient. That is the thing which we have done in our 20 cases. Pediatrics we are not touching. In pediatrics, the spontaneous resolution is there, but we are getting a patient of pediatrics, what you call, but if vision is left, we are operating. If vision is more than 6/18, we are not operating in these cases. As far as cataract formation is there, that is the issue. That's why we are not operating. So this is the case, the talk I am giving, because the early identification is very important. No one diagnosed or referred it. We have got the patient who was a IAS, this is a IB officer, he was having 630, not able to detect the vision. So for younger generation, you must do OCT, and if there is a macular detachment, you must see the pit and refer the patient as early as possible, or follow up in your clinic till the NSD occurs and vision fall and patient is agreeing for the surgery.
Thank you so much, sir. Thank you.
Thank you.
Next, we have Dr. Stuti about demystifying electrophysiology.
Good afternoon. I'll be talking on basics of electrophysiology. Direct quantitative objective assessment of the visual pathway at different levels. ERG is at the level of the retina, VP at the level of visual cortex, and EOG at the level of RPE. Full field electroretinogram is a mass electrophysiological response to diffuse flashes of light, and it used to assess generalized retinal function. ICEF has standardized the full field ERG into total of 6 responses. The first 4 are the dark responses, and the last 2 are the light responses. The 3 electrodes are active electrode is placed at the cornea, reference at the outer canthus, and ground electrode is placed at the forehead. Pupil is dilated. There is 20 minutes of dark adaptation for recording the scotopic responses and 10 minutes of light adaptation for recording the photopic responses. Dark adapted 0.01 is a single flash rod response. It's a pure rod response. There's a slow positive B wave only. Reduced amplitude or prolonged implicit time is seen in conditions affecting the rods like RP and CSNB. Dark adapted 3 ERG is a combined rod and cone response. A wave is from the photoreceptors and B wave is from rod and cone bipolar and Muller cells. Dark adapted 10 ERG is also a combined response to stronger flash, and it is more informative in patients with opaque media, small pupils, or immature retina. B waves are the ones that arise largely from rod-driven on bipolar cells. Dark adapted 3 oscillatory potentials are low amplitude wavelets superimposed on B wave. Primary contributor is amacrine cells. It's sensitive to effects of ischemia and decreased in ischemic disorders like DR and CRVO. Photopic ERG, the first response is light adapted 3 cone response. In this, A wave reflects the function of cone photoreceptors and off bipolar cells, and B wave reflects from on and off cone bipolar cells. Light adapted 30 Hz flicker is recorded to repeated standard flashes at frequency of 30 Hz. It's more sensitive measure of cone system dysfunction and generated by cone on and off bipolar cells. Amplitude is from trough to peak of each response, and peak time is around 24 to 27 milliseconds. Latency is the interval to the commencement of A wave after the stimulus is applied, and implicit time is the interval from the stimulus to the peak. B wave amplitude is measured from the A wave trough to the B wave peak. Indications of ERG are photoreceptor dysfunctions like in retinitis pigmentosa, inner retinal dysfunctions as in CSNB, inner retinal dysfunction with vascular etiology like in CRAO, and drug toxicity like in HCQS. Diseases affecting photoreceptors produce abnormal A and B waves. Disease that affects only the bipolar cells leaves the A wave intact, which is the electrode-negative ERG seen in CSNB. Completely extinguished ERGs are seen in Leber's congenital amaurosis and severe RP. This is a printout of full field ERG, the normal ERG, where the first 4 responses are dark adapted and the last 2 are light adapted. Pattern ERG is localized retinal response evoked by contrast reversing pattern. No dilation of pupils to maximize the retinal image quality. It's dominated by the response of RGCs driven cone photoreceptors. The waveform includes an initial negative N95 followed by a larger positive P50, which is followed by a larger negative N95 component. It differentiates between macular and optic nerve disorders. In macular disorders, P50 is abnormal, and in ganglion cell disorders, N95 is abnormal. This is a printout of a normal pattern ERG with normal P50 and N95 amplitudes. Multifocal ERG are cone-driven bipolar cell activity. It provides insight into macular pathology. Patients must maintain accurate fixation, so pupil dilation is not required. Multifocal ERG assesses many local ERG responses, 61 or 103 hexagons within the central 40 to 50 degrees. There is an initial negative deflection N1 followed by a positive P1 and followed by a negative deflection N2. MFERG is used in diagnosing retinitis pigmentosa with central involvement, Stargardt's disease, HCQS toxicity, and BRAO. EOG records the standard potential between front and back of the eye, which depends on integrity of RPE. The ratio of highest amplitude recorded in light adaptation to lowest amplitude recorded in dark adaptation is given by Arden's ratio. More than 1.8 is normal and less than 1.65 is abnormal. EOG abnormalities are proportional to severity of rod-mediated ERG abnormalities and are not of diagnostic importance, but the exception is best vitelliform macular dystrophy, in which full-field ERGs are normal and EOG is abnormal. Visually evoked potential electrophysiological responses to pattern of flash stimuli recorded over the occiput. It's valuable in diagnosis of optic nerve disease and is a method for assessing function of visual pathway from retina to the primary visual cortex. Recording the VEP requires a natural pupil size. Records are best taken at a fixed distance. The non-stimulant eye should be included. Pattern VEP has a first negative waveform, which is N95, first positive, which is P100, and second negative, which is N135. The main measurements are the amplitude and the latency of P100. This is a normal pattern VEP printout in which the P100 amplitude is normal and there is no P100 latency. The optic nerve demyelinating diseases like optic neuritis and multiple sclerosis, in this there is VEP peak time delay. And in optic neurodegenerative diseases like an optic nerve atrophy and ischemic optic neuropathy, there is a decrease in amplitude. Flash VP is a crude reproach. It indicates that light has been perceived. It is unaffected by opacities in lens and cornea. It is useful where there is limited cooperation, and it is done when pattern VPs are not recordable. This is a printout of a normal flash VP. It shows N2P2 amplitude, which is normal, and there is no latency. How to select visual electrophysiology examinations. Optic nerve disease, you should check pattern VEP. Where pattern VEP is not possible, you can do a flash VEP. Eye trauma, you have to check for VEP, pattern and flash. Hereditary retinopathy, full field and pattern ERG or multifocal ERG. Vascular retinopathy, full field and multifocal ERG. Macular diseases, multifocal ERG and pattern ERG. Toxic retinopathy, full field and multifocal ERG. Glaucoma, pattern ERG, and unexplained visual loss, check pattern VEP or flash VEP where pattern is not possible. So there are two cases. The first one is a case of retinitis pigmentosa. When we went ahead and did the ERG, there are completely extinguished waveforms in the first 4 dark adapted and also in the light adapted. The second case was a 24-year-old male. The visual acuity was 6.6, but the autofluorescence showed us that it was a case of Stargardt's disease. We went ahead and did multifocal ERG. There was diminution of central amplitudes in both the eyes. And the full field ERG, the rod adapted, the dark adapted, and the light adapted was absolutely normal. Thank you.
Thank you. Very good presentation. I think you have summarized everything, the ERG and VER as such. Tell me the few condition which you would like to do, one or two.
Basically, we would like to do.
You are in a medical college?
No, I'm in the Shofai Center.
Private there.
Private,
The
yeah.
ERG, VR is there.
You
tell me
for
the
hereditary retinal degeneration.
Okay, that is the one condition.
So retinitis pigmentosa and also in Stargardt's disease.
Stargardt disease. Good.
But before doing the ERG, you should mention what dark adaptation, visual fields, these are more important than ERG.
Yes.
Number 2,
Yes.
this VEP is meant for the cortical blindness also.
Yes.
So, not only the optic, the
Yes.
should always do this in the cortical also, huh?
Yes, ma'am.
Thank you, Dr. Stuti.
Welcome.
Next, we have Dr. Sangamitra. Dr. Sangamitra is here.
नहीं है शायद.
Then we'll go ahead with Dr. Ajay Arora, sir.
Dr. Ajay Arora. Need
Sir
no
will be-
introduction. हाँ बताइए introduction. हाँ.
Sir will be speaking on persistent macular edema. Can suprachoroidal injection of triamcinolone be the game changer?
He is basically innovator, one of the innovator in AIOS. He is inventing many things. I think he has already invented many things. I don't know how many he has patented. After the talk, he will discuss with us. So now he is going to talk on persistent macular edema, suprachoroidal injections. Mike.
Sir, and thank you for the AOS for giving me this opportunity. I'll be talking on persistent macular edema and is suprachoroidal injection of triamcinolone the game changer. So we know that how do we manage persistent diabetic macular edema or persistent macular edema. These are the various options that are available to us, but there are cases where macular edema is persistent despite these interventions. So for the aims and options of this presentation is how do we control this in a manner which is relevant to our country, which is not as expensive. So we have devices like Ozurdex available, which we keep injecting. We have the other options available are Iluvien, which works out to about almost $9,000, and we have Zipera, which was made by Clearsight Biomedical, which is again a suprachoroidal injection of triamcinolone, and which actually drove me to do something which Clearsight Biomedical was doing. And surprisingly, this company is basically it is based on a microneedle concept. So all these agents cause cataract, IOP increase, may cause infection, may cause retinal detachment. So can SKITA be the game changer? When we inject triamcinolone into the suprachoroidal space, it spreads to an extent which involves more than 50% of the posterior segment. The problems with suprachoroidal injection is that it's a blind procedure. It goes into a space which is virtually non-existent, but when expanded can take up almost 1 ml of fluid, and we can inject with a microneedle. But for all these micro injector systems are available, and the efficacy for the triamcinolone working in the suprachoroidal space is proven. There are umpty number of presentations which show that the triamcinolone is effective. So these are the various devices that are available at the moment. One is by the Clearside Biomedical, then this microcatheterization which has been abandoned by Medven, and then the eye track mechanism by iScience. So the basis behind this is a microneedle, which is difficult to get because a microneedle is a needle which has a bevel of less than 300 microns. A normal needle has a bevel of 1200 microns. So people have done a jugaad by combining a 30 gauge needle with a 23 gauge needle, which I know you get it from Pricon, but sometimes these are not very consistent, and it's not consistently worked in my hand, but yes, it can work. So the question for me was to see if a normal 30 gauge needle can be used for suprachoroidal injection. So we constructed a study, we did some animal studies, and then we went on it and did a human pilot study. And now I've injected almost 128 eyes, and so the basic concept of the device is that you have to enter obliquely and not vertically, because if you enter vertically you will get into intravitreally. If you enter obliquely and you have nomograms, then we can enter into the suprachoroidal space. So this is the device which is almost got patented, and once it's done it will be available for everybody to use, and this is the device which I've used for this. So this is initial animal experiments we did in goat size, which shows that the device is being injected. We went ahead and injected the triamcinolone and methyl cellulose and helon, and you can see the expansion of suprachoroidal space. And once injected, we dissected out, and we could show that triamcinolone was present in the suprachoroidal space. So that was very convincing. We went ahead and injected the dye in. This is how we do it. It's either done in the infratemporal or in the infranasal quadrant, and it works out very, very smoothly. It's done 3.75 millimeters from the limbus, and the cost of the injection is just a 2 rupees 30 gauge needle, and plus the drug cost, and it works extremely well. This was one of our initial studies. Now we have a much larger group of patients available, so I'm just presenting the initial data, and this has been done for varied cases. So like this was an example, and I tested that out way back in 2020 when you remember Ozurdex was not available in the country. So this patient was a bilateral diabetic macular edema, had got anti-VEGFs as well as got Ozurdex, and also Ozurdex was not available. How do we go about treating? We took the consent, injected triamcinolone into suprachoroidal space, and you can see how the beautiful response was on the 14th day. And this response lasted for about 88 days, and then it had to be repeated. This is a patient who had uveitis and had received systemic steroids. He came to me, and this time he did not wish to have systemic steroids, or he did not wish to have Ozurdex. So we gave him suprachoroidal triamcinolone, and it again worked. So this is an interesting case of non-infectious uveitis, whom I have now followed for almost 3.5-4 years. Who be treated with the triamcinolone. The effect lasted for about 4 months. You can see the response over a period of 4 months. And then we went ahead and did something very interesting. We decided to centrifuge the triamcinolone. So normal triamcinolone is 1 ml triamcinolone or the cot, 40 milligrams is available, and 0.1 ml you get 4 milligram triamcinolone. We centrifuged the triamcinolone. We removed the supernatant. We are left with a small pellet of 0.2 ml. We then dissolve it, and in that pellet we have triamcinolone of about 0.1 ml, which contains 20 milligrams. So we inject about 0.05 ml to 0.75 ml. We inject almost about 10 to 15 milligrams of triamcinolone into the suprachoroidal space. So we did this in this particular patient, and you see the effect of this triamcinolone lasted for 8 months. There's no single agent available anywhere in the world where you can have an effect lasting in a patient for 8 months. So the same patient came back, and the next time we injected in the same patient, the effect lasted for 7 months. So this patient, over the period of 4 years, I've injected 4 times, and the patient has responded extremely well and is doing well. What I need is a larger institutional study, because in the private practice you can't have so many patients, because you have to be extremely selective. You have to take a consent. But in conclusion, suprachoroidal injection of triamcinolone is a safe and effective method. It is cheap. Centrifugation has allowed us to extend the period of effectivity for almost about 7 to 8 months. It does not produce cataract or glaucoma because it lies into suprachoroidal space. In our 128 eyes, 4 cases we had increased on intraocular pressure. No patient developed cataract. I think it can be a game changer in the long term for management of diabetic macular edema and other persistent macular edemas. And this device is actually can also be used for various other indications for injecting agents into the suprachoroidal space. Thank you for your. Thank you very much.
Very good presentation. Dr. Ajay Arora is last 4-5 years trying hard in this. Can you tell me what are the initial complications in these cases? One.
I didn't find any complications, sir.
Okay, because many of the center people are not ready to do this thing. In the beginning, we have also tried, but one patient developed secondary glaucoma. All these things.
So you develop secondary glaucoma if your drug is not going into the
that may be
space.
the technique and experience is required. Ne?
So what I am doing now, which is not presented here, is that this injection would become more automated. Because the biggest problem comes up is you do not know when you are into the suprachoroidal space. So if everything comes out right, it's very premature for me to say, but if everything comes out right and we have a small little device which will be attached to this particular thing, that the moment you get into the suprachoroidal space, you will get a sound signal that you're in the suprachoroidal space. If that happens, you know when you are there.
I think you should consult the institutions there. So you have done a
So I
great
have
work.
given an
You are
offer to-
welcome, RP Center, because
So it's very interesting, OCT guy, but OCT actually cannot pick up the suprachoroidal space. So it's only in rare circumstances that with the OCT you can pick up the suprachoroidal space. OCT does not pick up the suprachoroidal space. And interestingly, after injecting into the suprachoroidal space, we took the patient we did a wide field imaging, and we were not, because the distribution happened so rapidly, we did a UBM in these cases, and with the UBM also we were not able to demonstrate. What I showed you, the UBM pictures, were when we injected methyl cellulose and helon in the suprachoroidal space in the animal eyes. There you can demonstrate, but if you inject that 0.05 ml of triamcinolone, it just spreads so rapidly that you can't detect on the UBM. I have used the commercially available needle, and I have somehow personally, for me, I have not succeeded because I am not able to find this. But I've talked to people and they said sometimes they're able to find the space, because what happens is the thickness of the sclera varies in all quadrants of the eye. The thickness is, so we did an initial study of measuring scleral thickness in various quadrants: supratemporal, supranasal, infratemporal, infranasal, and in the horizontal quadrant. You should never inject in the horizontal quadrants, because you have the long posterior ciliary nerves there. If you inject there, the patient will have severe pain. So that is one thing which you should avoid. But otherwise, you can certainly go ahead and inject with the Pricon needles. But I have personally failed. This device I have given to Pricon, and somehow they have not, they thought that they will be able to do it and make it better, but I think they have probably taken the ideas and incorporated in there. But that's what happens in the country, that you can't really progress in a proper way. It doesn't happen. So I'm very unhappy with it. Sure, definitely.
So that is why I am asking him. He can collaborate with the institution like Dr. RP
So
Center
I
or the
think
individuals.
within a month I will have the patent in my hand, and once that happens, because there's some delay, so once that patent happens, I think I should.
Nee,
be
but
able to
supracaudal injection, you don't require patent. You can train and.
No. So for the device, not that it matters. I have no commercial interest, but since I don't want that this device should give me any benefit commercially, but at least it will benefit humanity. I think it's because of the particle size. So I have another small study on scanning electron microscopy. I have not presented here. Is what is the particle size? But washout period, I don't think I know because it's in the supracranial space. We can't even detect where the drug is. I don't have mechanisms to detect with UBM or with OCT. So how do I know washout is active? But it is effective,
So
Before giving this thing, you have to exclude patient of steroid responder.
It is a more
Steroid
advantageous than posterior
So posterior subtenons can those patients have increase of intraocular pressure. The main concept is the anatomical space, supracoroidal space. The supracoroidal space ends at the ora serrata and goes up to the optic nerve. So it does not communicate with the anterior chamber. It does not communicate anywhere else. So if you are right in the supracoroidal space, you cannot cause glaucoma. But still, some of the particles may leak out, and then they have detected and they can have some effect. So it's not that 100%, nothing in science is 100%, but mostly it will not cause it.
Thank you, sir. I think you should coordinate with us, and this may be the better therapy in the futures.
Thank you, sir.
Very good. You can ask in the lunch from Dr. Ajay Arora how to give. Dr. Ajay, you must stay here for the benefit of the.
This is
Dr. Megha Gulati. We have Dr. Abhijit Chattopadhyay with us, but he has to leave for another session. So would you like to join for one talk here?
No problem, I will use this mic. Good afternoon all. I will be dealing with few important pearls regarding the pathophysiology and the pharmacokinetics regarding the pseudophakic cystoid macular edema, which we deal in and out every day. So why does the vision drop usually occur 4 to 6 weeks classically post-surgery? So patient usually says that my vision was very good after cataract surgery and after 4 weeks it has suddenly dropped. This is because when there is surgical trauma to the iris and ciliary body, and which leads to disruption of the blood aqueous barrier, there are release of prostaglandins, VEGF, and interleukin growth factors. It diffuses through the vitreous to the retina and it takes time. So it takes almost 3 to 4 weeks for blood retinal barrier to get disrupted, leading to cystoid macular edema. Now we classically see a yellow dot at the fovea. So why is it seen, and why is it seen exactly at the center of the fovea? Now there are xanthophylls which are accumulated in the region of the photoreceptor axons and outer segments, which are most dense in the center of the fovea. So whenever there is a prominence of neurosensory detachment which is there, it leads xanthophylls to come little forward and leads to the yellow dot. So it represents an acute event. You will never see that in a chronic case of cystoid macular edema. So whenever there is a neurosensory detachment, there will be a yellow dot with the CME. Now, why does it occur only at the fovea and not at the other parts of the macula? Now, there is a high metabolic demand at the fovea. The cell dysfunction, it causes increased metabolite accumulation and because of the foveal avascular zone and watershed arrangement. So I will explain this, why there is high metabolic demand. Now, the cone nuclei, they are bunched up and longer in size at the foveola, so they have more demand and then it leads to more of metabolite functions, and the other retinal layers, they are laterally displaced. The other reason is that foveola itself is avascular, while there is the watershed zone, outer retinal nutrition and the inner retinal nutrition is dependent upon the choroidal and the retinal vasculature respectively. Now we see, the name suggests there is cystoid macular edema, the cysts are formed. So we'll see in which layers are they formed, why are the central cysts larger in size, and how are the cysts distributed. Now the first point, in which layers are the cysts formed? So here we'll see the retinal vasculature. So there is a superficial capillary plexus in the ganglion cell layer. In the inner and the outer side of the inner nuclear layer, we have the middle and the deep capillary plexus. Now the principal site of the blood retinal barrier breakdown is the middle capillary plexus, that is the inner side of the inner nuclear layer. So inner nuclear layer is the most common site for pseudophakic CME, and on either side of the inner nuclear layer, that is the inner plexiform and the outer plexiform, they act as diffusion barriers. So the cystoid macular edema, it occurs in the inner nuclear layer most commonly, followed by the outer plexiform layer. Why are the central cysts larger in size? To understand this, let's understand the arrangement of the Muller cells. They have a Z-shaped morphology at the fovea and the foveola. So initially we have a short vertical segment extending from the external limiting membrane to the outer nuclear layer. Followed by that, there is an intermediate long oblique portion along the outer plexiform layer, that is the Henle's layer. Then we have a vertical segment from the inner nuclear layer to the termination of the ILM. Now at the fovea, exactly these Muller cells, they are widely spaced. So therefore the central cysts are larger in size. Muller cell axons are arranged in an oblique pattern as we saw, and they are more widely spaced, though larger cysts are at the center, and the perifoveally we have the smaller cyst. Other pathophysiology which has been explained for central larger cyst are that the Muller cells, they are themselves swollen and degenerated, which leads to the formation of the cystoid spaces. Now, how are the cysts distributed around the fovea? This helps us in differentiating the pseudophakic cystoid macular edema from other causes of macular edema. Now, they are equally distributed. So, you can see that exactly if you bifurcate at the foveola, on either side there will be large cyst, then surrounding will be the small cyst. This is not the case in tributary vein occlusion and diabetic macular edema. Here we can see the cysts will not be equally distributed around the fovea. Now, if we see the fluorescein angiography, clinically we can see pseudophakic CME in only 1 to 2%, but there is angiographic evidence in more of the patients. So, classical angiographic picture will be that in the initial phase, there will be pericapillary dilatation at the foveola. Then there will be the pooling of fluorescein dye in the cystic spaces. Now this pooling of dye will lead to a characteristic pattern which is called the petalloid pattern, and based on that it has been graded whether the petalloid pattern is partial or complete. Now why is this there a petalloid pattern? So petalloid pattern has two components to it. One is the hyperfluorescence and one is the hypofluorescence lines which are there in between the petals. So the pooling occurs under the larger paramacular vessels. So these paramacular vessels, they stand up, which gives us the black line between the petalloid patterns. Now the treatment, as we all know, it can be in form of topical NSAIDs and steroids. Now the pathway which is blocked by the steroids and topical NSAIDs, it's different. So initially we can give topical NSAIDs, but usually periocular steroids are required. So we can start with topical NSAIDs, and then along with that, if you're giving periocular steroids, you have to wait for 1 month. Call the patient after a month. If the patient improves, well and good. If the patient does not improve, there is no sign of improvement, then you have to shift to intravitreal steroids. If there is sign of improvement but it has not completely resolved, you can repeat a periocular steroids. In rare cases, when it is not responding to any form of steroids, then we can go ahead with YAG laser vitreolysis if it's a case of complicated cataract surgery, or along with that anterior vitrectomy or pars plana vitrectomy. Now, amongst the topical NSAIDs, the most preferable one is Nepafenac. Why so? Because it has a superior corneal penetration. The therapeutic levels in retina, they are sustained, And the amphenac, which is the metabolite of nepafenac, it has higher COX-2 inhibition. So COX-2 to COX-1 ratio is higher for nepafenac. The other one, if you want to try, is the second preferred one is the bromfenac. Now, the last point and a very important point is if you have a patient of pseudophakic cystoid macular edema, what about the contralateral eye? Now, there is almost 50% risk that the other eye might also land up in pseudophakic cystoid macular edema. So, you have to counsel this patient, and whenever you're planning for cataract surgery, start 1 week, 3 days prior with topical NSAIDs, or you can give periocular steroids to these patients. Thank you.
Thank you, doctor. Next, we have Dr. Ajay Kapoor. I would like to request all the presenters to please take on time. We are running late. Dr. Ajay Kapoor. Dr. Prashant Jain is here.
Thank you, organizers, for giving me this opportunity. I'll be speaking on the management of diabetic macular edema. So basically, management of diabetic retinopathy deals with management of diabetic macular edema and dealing with complications of PDR. So this talk is about DME. To tackle DME, we have laser photocoagulation, which we used to do many years back, but now it's getting reduced because of the availability of injections. If we are talking of injections, then now we have so many possibilities available that we are spoiled for choice. And then there is also a role of surgery for vitreomacular traction cases. And last but not the least, metabolic control has to be emphasized in order to manage these cases. So what drug to choose? Each drug has its own pros and cons, and what regime to follow. This is basically the topic of this talk. Should loading doses be given, and is PRN right from the word go? What is the end point of injections? To be honest, there is no end point. Patients keep on getting these injections. And what about non-responders? There will always be non-responders, whatever drug you may choose. And then there are complications of intravitreal injections. So this talk is about early intervention, which leads on to lasting benefits. And in these trials which I mentioned, Vivid and Vista, they shown that visual gains were observed as early as the first injection of aflibercept. Why we are talking only of aflibercept or Eylea? Because it's become standard of care now. All the studies, new molecules are coming, they are dealing with non-inferiority as compared to aflibercept. And patients, they received greater than 8 injections through year 1. They maintained these vision gains. And across all these studies, patients treated with aflibercept, they gained an average of greater than 10 lines. And all the international guidelines, recommendations, now they support the use of early intensive treatment. So that's what you have to emphasize to your patients. To get the treatment as early as you detect them with DME, you have to spend time with them, you have to counsel them, you have to show them the results of the various studies so that they can agree with these early interventions. And also you see these studies also show us that 87 to 93% of the mean letters gained at 1 year had been gained after 5 monthly doses of aflibercept. So the early, what we call is the loading dosing thing is very necessary. Mainly in private practice, what happens is when a patient comes to you, you detect him with diabetic macular edema, you just talk to him and tell, okay, you need an injection, but you never emphasize upon the possibility of many injections because you don't want to lose the patient. Once you're talking about 5 injections to the patient, the cost involved in the patient, you are afraid that he'll run away. So why should I lose opportunity even about 1 injection? But this is needed if you really want to retain the patient for long. And this also study, this graph shows that delaying aflibercept treatment led to poor vision outcomes because here you see that these in the lower line, the light gray line, it shows that the patients who had received laser, once they were eligible to receiving intravitreal injections, they did not gain the vision, which the upper 2 lines show, which the patients who were given early injections. And this graph shows you that the intensive anti-VEGF treatment in year 1 may facilitate a reduced injection burden thereafter. So this is what we need to explain to the patient, that if they are getting injections every month or so initially, later on in year 2 and 3, their need for injection goes down. So ensuring adequate continued follow-up and treatment as required after the initial loading dose can maintain vision gains seen early in the treatment through even to year 5. See here, the vision gains with aflibercept were sustained through year 2 with a reduced treatment burden in protocol T of DRCR net. And this slide shows that the randomized controlled trial experience can be obtained even in the real world experience with early intensive treatment. These patients who received, the Moorfield study shows that these patients who received approximately 7 injections in year 1, they had gained about 11.2 ETDRS lines. And the other graph shows that patients who had not received this, the gain was very poor. So in summary, we can say that early intensive treatment with greater than 7 injections or 7 injections in the first year can deliver clinically meaningful visual gains equivalent to randomized controlled trials. And the take home message should be that based on these studies, we need to change our thinking of management of diabetic macular edema. We need to counsel the patients for early intensive treatment. And how to do that? It is that you can give them complementary OPT visits, you can give them complementary OCTs. And what I have started doing in order to promote this better molecule is I am giving bilateral injection the same day, because the drug is enough to be divided it into 2 eyes. And in the same cost, I am not increasing the cost. So I am reducing my profit margin in order to give a better molecule to the patient. You can also do telecounseling to the patients who are not following up. And I think we should all pool our data and our own real world experience publication. Thank you very much.
Thank you, sir, for finishing on time. Next, we have Dr. Divya on non-ICGA based diagnosis of PCV. Where is it? उधर तो नहीं है।
A very good afternoon, everyone. I'll be talking on non-ICGA based diagnosis of PCV. Next slide. It's not moving. Okay. So, polypoidal choroidal vasculopathy is a subtype of neovascular AMD characterized by nodular dilatations within type 1 neovascular networks that are best seen on ICG angiography. Prevalence of PCV among neovascular AMD is noted to be higher in Asians compared to Caucasians in various studies. So why to differentiate between PCV and neovascular AMD? So the initial differentiation of PCV from typical neovascular AMD may not be essential when commencing treatment, because many clinicians will use anti-VEGF monotherapy as their first line modality for all subtypes. However, if the disease activity remains persistent after initial 3 monthly doses, diagnosing possible PCV subtype becomes important, because a change in management plan may be beneficial. So, although ICGA remains an important imaging modality in current clinical practice, fewer clinicians tend to perform dye angiograms because it is an invasive procedure, it's time consuming, and it requires special dye and equipment, which are available only at large ophthalmic centers. Moreover, ICG is contraindicated in patients with impaired kidney and liver functions during pregnancy, and with patients with history of allergy to iodine-based dyes. So leading to the possibility that PCV cases may be missed in clinical practice. So now the question arises, can we use alternative imaging modalities to accurately diagnose PCV without use of ICGA? So color fundus photography and OCT are available in most of the clinics. Color fundus photography is a non-invasive and widely available tool. CV et al. Showed that it has high sensitivity and high specificity to diagnose PCV when it is used in conjunction with OCT. So hallmark features on color fundus photography include subretinal orange-red nodules, massive subretinal hemorrhage, peripapillary location, and no large druseness. OCT being another widely available lower cost tool, and there is a larger pool of diagnostic experience to draw from compared with ICG. The hallmark features of PCV on OCT include a notched PD, a peaked PD, hyperreflective ring underneath PD, and the double layer sign. So DeSalvo et al. Showed that with presence of 3 or more OCT criteria of multiple PDs, sharp peak PDs and PD notch with a hyperreflective ring beneath RP had 95% of sensitivity and 93% of specificity to identify PCV. CV et al. Noted that presence of 2 or more of 4 features are highly suggestive of PCV, features being notched or hemorrhagic PD on color fundus photograph, peaked PD with angle of 70 to 90 degrees, PD notched with or multilobulated PD, hyperreflective ring with hyperreflective lumen underneath PD. Now coming back to prevalence, PCV may be underdiagnosed in Caucasians as ICGA is not routinely performed. So a multi-center retrospective study conducted on prevalence of PCV based solely on non-ICG diagnostic criteria in Hispanic and non-Hispanic whites with neovascular AMD. It included 145 eyes from 8 centers of non-Hispanic regions and 52 eyes from Hispanic population. 3 retina specialists confirmed neovascular diagnosis based on color fundus photograph, OCT, and fundus fluorescein angiography. And 3 retina specialists diagnosed PCV on color fundus photograph and OCT alone. Based on 2 or more features, prevalence of PCV was noted to be 23.4%, even in non-Hispanic white population, which is quite comparable to Asian population. Similarly, another study on 100 Caucasian eyes in Australia, based on the OCT diagnostic criteria, found that 22% of the eyes had OCT diagnosed PCV in that population too. Asia Pacific Ocular Imaging Society PCV work group added another OCT feature, which is hyperreflective BVN connecting multiple PEDs, which is only seen on Zeiss SG-OCT or Octa devices. So what other potential benefits can anti-VEGF therapy provide for patients with PCV in addition to clinically meaningful vision gains? So vision gain remains the most important outcome. However, anatomical outcomes like complete polyp regression, reduction in number of polypoidal lesions and polypoidal lesion areas, and inactivation of polypoidal lesion may be targeted. Planet was multi-centered phase 3b4 RCT in which participants received 2 mg of aflibercept at week 0, 4 and 8. At week 12, participants with a suboptimal response were randomized to 1:1 to receive aflibercept plus sham PDT or a rescue of aflibercept plus rescue PDT. So patients in the aflibercept monotherapy arm achieved substantial vision gains of more than 80%. And like 80% of the eyes showed no evidence of active polyp at week 52. That means it has really helped in polyp regression over 1 year. So in other studies across the globe, patients treated with aflibercept achieved favorable vision gains and complete polypoidal lesion regression up to month 12. Another retrospective study conducted by Mio et al. On 37 Japanese eyes with PCV, where aflibercept treat and extend was followed for 2 years, and with eyes with complete polyp regression group had less recurrence rate, they received less number of injections, and they had longer treatment intervals. So to summarize, ICG remains the gold standard for the diagnosis of PCV. However, alternative imaging modalities like color fundus photography and OCT can be used where ICG is not available. Alongside with achieving clinically meaningful vision gains, aflibercept monotherapy can achieve complete polypoidal lesion regression as early as month 2 in patients with PCV and can achieve higher rates of polypoidal lesion inactivation. So these findings support consideration of aflibercept for PCV to achieve both good anatomical and visual outcomes. Thank you for your patient hearing.
Thank you, Dr. Divya. We have the last talk for the session by Dr. Prashant Jain. Topic is case-based insights in DME. I apologize for the members of the next session. We got the hall late, so we are
Slides,
running a
please.
little late.
Good afternoon, all. So I will present few cases on DME, treatment-naive DME, my experience with aflibercept. So it's a buyer-sponsored session. These are my financial disclosures. Slide. So case 1, it's a 48-year-old male who is a known case of diabetes mellitus for 10 years, and HbA1c was quite uncontrolled, 11.1. Initial best corrected visual acuity was 612 N8 and 618 N10. So this was the clinical picture. There was mixed retinopathy both eyes, and this was the FFA. So there was marked CME with SMD in both eyes, and in left eye there was schisis-like picture also. So patient was treatment naive and decided to go with the 3 loading dose of aflibercept. So this was the first loading dose. Then after 3 loading dose, still there was edema, and I advised the 4th injection, but BCVA improved to 6.6 N6 in right eye and 6.12 N8 in left eye. So patient missed the anti-VEGF in both eye at 4th month, but came in 5th month for next follow-up with improvement in BCVA both eye, but minimal increase in CME. So you can see the CME has increased, and patient has missed the 4th dose after the, here I have advised the 4th injection. So then patient was quite compliant after that, and routinely I was giving anti-VEGF, then April, June, September. This was the picture of December and then April. So the last follow was in July 2025. There was minimal edema in both eyes, and there was quite improvement on the FFA also in both eyes. So this patient, I have 35 months follow-up. Patient took 9 aflibercept in each eye. First year, he took 5 aflibercept, second 2, and the third year, again 2 aflibercept. So there was marked improvement on FFA also, and patient is maintaining BCV at 6.9 and 6 in both eyes. And now HbA1c is also quite controlled, 6.5. Initially, it was 11.1. So case 2, it's a 48-year-old male. HbA1c is quite well controlled. There is no other systemic illness. Patient presented with diminution of vision both eyes, and best corrected visual acuity was right eye 636 and 18 and left eye 636 and 24. So this was the clinical picture. And FFA, there was PDR, there was NV, multiple NVs with CNP areas in both eyes. So this is the left eye. And there was marked edema with schisis-like picture in both eyes. So I decided to start with the 3 loading dose of Eylea. So this I gave, and there was marked improvement on first injection, then second, then third. And then after every 3 months, there's recurrence. So I have not posted the images of the no edema picture. So every 3 months, I was giving injection. So there was quite improvement on the FFA also, and I did PRP also both eye 3 sitting. So after giving 5 anti-VEGF of aflibercept, I decided to shift the patient to brolucizumab, and then there was recurrence after 2 months when I shifted the patient to brolucizumab. So again, I thought to give the second brolucizumab, and I again gave brolucizumab at this picture, and again there was after 2 months there was recurrence. So with aflibercept, patient was maintaining 3 months follow-up, but after shifting to brolucizumab, the recurrence was at 2 months. So then again I shifted the patient to aflibercept, and then patient was maintaining 3 months duration between the 2 injection. And in 2024 till date, patient took 6 aflibercept, 2 brolucizumab, and he was maintaining 6.9 and 6 in right eye and 6.12 and 8 in left eye. There was drill in both eyes on OCT picture. So I did, this is the picture of 2024. Again, the CME was there. So then I decided to switch to faricimab in both eyes. So this is the picture post 6 week of the first faricimab. There was quite marked improvement even in vision. So then I shift, but that in 10th week, the patient presented with recurrence. So there was recurrence at 10 week, but I again gave second faricimab in both eyes. Again at 10 week, there was recurrence. So I decided to give aflibercept in right eye after 2 faricimab, and I decided to give third faricimab in left eye. So at 12 week, there was minimal fluid was there. Yeah, definitely recurrence was there at 12 week in right eye, where I have shifted again the patient to aflibercept. But there was marked CME in the left eye, where I have given third faricimab. So then again I shifted patient to aflibercept, and now almost every 14 to 16 week there's recurrence, and patient is taking aflibercept only. So this is the last picture. So it's a compliant patient. HbA1c is 5.8, almost 39 months follow-up. Right eye BCVA is maintaining 6, 9, and 6. Left eye 6, 18, and 8. Almost took 9 aflibercept, 2 Broly, and 2 Farici in right eye. So finally, I shifted back to aflibercept. The duration between 2 injections is stretching to 13 to 14 weeks, which was only 8 weeks in brolucizumab and 10 weeks in faricimab. So third case, patient known case of diabetes and hypertension, known case of CKD, uncontrolled HbA1c, vision 660 and 36 both eyes. So this was the initial picture when patient presented to me with CME with SMD. So FFA I deferred due to the CKD status, and I decided to go ahead with the 3 loading dose of aflibercept. So there was marked improvement after the first dose, and the vision improved to 6, 12, and 10 in right eye. And this is the left eye. Even after first dose, there was marked improvement, and the patient vision improved to 6, 9, and 6. So after 3 loading dose, patient was doing quite well. And in the first year, patient took almost 6 injection. HbA1c is quite well controlled now, and the BCVA at 1 year is 6, 9, and 6 in right eye, and 6, 12, and 6 in left eye. So there are several unmet needs with current anti-VEGF therapy in DME. There is long-lasting agents. We need some durability. Definitely better clinical safety models to detect early safety signals before entry into clinical practice. And individual healthcare jurisdiction is most important in cost and reimbursement policies. So VEGF and PIGF are elevated in patients with diabetic eye disease and plays a critical role in development of edema, retinal vascular permeability, inflammation, and neovascularization. And aflibercept with its inhibition of VEGF and PIGF leads to disease modification in DME. So the key messages are aflibercept is drug of choice for the treatment of patients with visual acuity worse than 69 ETDRS letters due to DME based on an independent head-to-head RCT, which showed superior versus other anti-VEGF agents at the primary endpoint. Aflibercept with intensive treatment in year 1 can modify the underlying disease and improve visual acuity outcome. And emerging real-world evidence is demonstrating the real-world effectiveness of aflibercept in DME. Thank you.
Thank you, Dr. Prasanjay. Now I think we will get for the photograph all the presenter just for a minute. और कोई है? नहीं? आ जाइए photograph. चलो.